This conference will now be recorded.
Welcome to.
Do you usually send out the links to the recordings afterwards?
We do usually send out the recordings to the links. Yes, if you sign up for our blog at AnCan.org and go to the blog page and sign up, you will definitely get it every time. Otherwise, you
Okay.
can go to our YouTube channel.
I'll put the address for the YouTube and AnCan in our chat box.
Thank you. Well, Alden is on the telephone, so he's not going to see it.
Oh.
But you'll get it off of AnCan.org, or you'll get it on YouTube, and yes, they are there.
Okay, thank you.
Sure. So welcome. We'll try again. Welcome to the AnCan high-risk recurrent advanced cancer meeting, prostate cancer meeting of the 4th of May. And we have a full house again. I will start by just doing a quick roll call to make sure that I've got everybody. We've got Bill Franklin, we've got Greg, Scott, Dennis Correa, Joe Blanchette, Larry Fish, Len, Les, Nazir, welcome Nazir, Nev Black all the way from the other side of the world, Paul Frieda, David Muslin, Jake, Dennis McGuire, Alden, Peter Kafka, and Russ Smith. Did I miss anybody? Okay.
First, we have to acknowledge Bill Franklin's new look. Totally clean shaven.
Oh my
I didn't even recognize him at first.
Oh my goodness, so it is. He looks like my buddy, he looks like Dave Fisher's younger brother, my buddy Dave Fisher's younger brother. Oh,
yeah,
good.
so I was out by the pool and I was trimming it without a mirror, and I didn't like the way it looked, and then I went in and tried to fix it, and then I really didn't like the way it looked, and then the whole thing just came off.
How long?
Start over.
How long since you were clean shaven? How long have you had a beard?
Oh, this was oh God, I've had a beard for about 2 years now. So
okay, all right.
Yeah. Ever since we've known him, he had a beard. I'd say maybe 3 years.
Off and on. I either had a goatee or a beard.
Yeah, I think it's longer than that, Mr. Franklin. Well, anyway, you look very good, and that's a good pickup there, my brother Len. All right, so what I think we're going to do, let's we've got 3 new men on the call, so we're kind of try and get through them in the first hour, 20 minutes each. Well, not quite now, just under 20 minutes each. And then I'll do a roll call again, and we'll see who needs time for today. So it looks like Alden has left. That was quick. So we got 2 new men. Such is life. Okay. Since we've got 2 new men, let's start with Greg, because Greg was on Peter's call. Greg is a high-risk diagnosis. He was on Peter's call, and so Peter and I know a little bit about him. I'm not sure if I have notes or not. Greg, can you introduce yourself? Tell us a little bit about your background, how old you are, and what your treatment path has been to date. And then we'll open it up and see if we can help you figure out the best way to proceed.
Hi, I'm Greg. I'm 62. I live in New York. So if any of you are familiar with urological specialists in the New York area, I'd appreciate you giving me some referrals that I can also see. I had a biopsy report done, and out of 12 cores, 4 were positive for cancer. I had 2 7s and 2 8s. Both of the 7s were 4+3. Few terminology in the biopsy report, like mucin extravasation, perineural invasion, and the cause. Very deep technical literature in the report. So a little help with those terms if any of you are familiar with it. I went to a consult for CyberKnife. I went to a robotic surgeon for a consult. I went to a radiation oncologist for a consult. Judging in terms of who I am, my lifestyle, I'm leaning towards radiation as opposed to surgery. My only concern is that I hope I'm choosing the right route. Some people that get radiation are not only getting radiation, but they're getting the brachytherapy with it. My urologist is just recommending hormone therapy along with radiation. The radiation is a combination of IMRT and IGRT. I start my first Lupron injection on Friday morning. I've done some reading about Lupron versus Degarelix, also known as Firmagon, and I saw some YouTube presentations that claim that Degarelix have less cardiovascular side effects as opposed to Lupron. I am a borderline diabetic. I'm not on metformin, but I'm borderline, so I'm concerned if I increase weight with Lupron, that would push me into a diabetic. And if I'm gaining weight, that's going to make me a cardiovascular risk. And I'm already on hypertensive meds. So when I see my doctor, I'm going to try to get to my doctor before Friday to see if he has any knowledge about the difference between Degarelix and Lupron in terms of posing any side effect risk for me. I think I've told you a lot, but I know time is limited, but I appreciate any help anyone can give me.
Okay. And where is your urologist and where is your radiation oncologist?
They are in a part of Long Island called Lake Success. What do you mean in terms of hospital affiliation or anything like that?
Yeah, I mean, which hospitals are they affiliated with?
Northwell. It used to be called Long Island Jewish Hospital.
All right. Yeah, Long Island Jewish. What's it called now?
Northwell.
Isn't it
Northwell.
North Shore?
But North Shore is also another hospital on Long Island. But LIJ was taken over by Northwell. So there's
Okay.
Northwell and then there's North Shore.
Right.
Okay. I'll just make a quick comment and then I'll throw it open and to give you some guidance. It sounds like you're pretty far down the road. The gold standard is probably to do the brachytherapy, the IMRT, and the hormone therapy. I mean, that is what has shown to have the best outcomes. There are other options, but they don't have as good outcome. When some other people get to be talking, I'll see if I can find the study on the brachy plus the IMRT plus the HT for you and put it in the window.
I'm sorry, go ahead.
And so, that's probably what I would say. I think if you haven't run the nomogram, the MSKCC nomogram, it's probably worth doing it. That'll, I suspect, justify to you that the radiation is a better course of action. It was in my case. I had a few more cores and I was a little bit younger. But it does seem to me that adding surgery for men who are have a 4+4 can often be redundant because so many of them need radiation and hormone therapy anyway. So that's my 2 cents. Who would like to jump in and provide any thoughts or advice?
Well, I have to agree with Rick on the gold standard there, Greg, and Rick is living proof that someone with Gleason 8 can have very long, durable remission. You don't often see that with Gleason 8 through 10. You asked about Degarelix versus Lupron. So yes, the general consensus is that Degarelix is safer for people with cardiovascular issues. If you're concerned about Lupron or Degarelix gaining weight while you're on hormone therapy, take metformin since you're pre-diabetic anyway. There's lots of evidence that particularly for diabetics, prostate cancer patients, that it does them a lot of good in addition to keeping your weight down. So what's the downside to Degarelix? It's a monthly injection in your gut, and most men have injection site reactions of pain, redness, and swelling that could last several days. I was on Degarelix for quite a while, and I just got fed up with it, and I switched to Lupron, which is much easier, at least in my opinion. It's a shot in your butt that you can get just once every 3 months or 4 months or even 6 months, although we don't recommend 6 months. And for me, at least, it was painless, no injection site reactions. So that would be the route I would take. But if you're concerned about cardiovascular side effects, you might want to start with Degarelix. See how well you tolerate it. You may be one of the lucky ones who has only mild reactions.
Mm-hmm. Okay, thank you.
I had a question, Greg.
Yes.
Have you had second opinion on this from anywhere other than these two primary doctors you're talking about?
You know, I'm glad you brought that up. I feel that they, on the one hand, I feel that they could be, I don't want to say minimizing treatment, but I want the best combination that would give me success. And I did read in Dr. Walsh's book, which just what Rick had said, the gold standard being brachytherapy, hormonal, and radiation. My urologist claims that brachytherapy has, he just said, too many side effects. Sometimes I don't know if he's saying it because he may not himself do it or he just doesn't have it as a part of his regimen. I did hear a talk by a Dr. Zalewski, who is a well-regarded practitioner of brachytherapy out of Memorial Sloan Kettering.
Correct.
He did say if men like me are already having urinary symptoms, such as frequency, getting up in the middle of the night to urinate, which is me, he said that it is for men. It works better in men who have no urinary symptoms. So that's why I didn't aggressively pursue the brachytherapy.
That is actually true. Shame on us for not asking you. And I actually have a good friend who had issues beforehand, and he got a lot of grief from his brachytherapy seeds for about a year. Eventually it settled down. Yeah. And yes, if you go in with any urinary symptoms, brachytherapy can be more troublesome. What I would say though is in that case to look at SBRT together with the IMRT or the IGRT because you can do the SBRT in 3 or 4 sessions, 5 sessions at the most, versus having to do 20 sessions or 25 sessions plus another 20, 25 sessions. So you can cut that down significantly. Have you considered SBRT at all, Greg?
Let me ask you, is SBRT another name for CyberKnife, or are they both used interchangeably?
So
Because I did have a CyberKnife consult.
CyberKnife is a type of SBRT. There are several people that make equipment, SBRT equipment, and CyberKnife is one of them.
All right, because I have a second consult with the CyberKnife specialist on May 11th. So I'll probably make a final decision somewhere around there.
Okay. Okay. You know, Larry, you were sort of asking about second opinions. What is on your mind? Why, if you were in Greg's shoes, why would you be looking for a second opinion?
Well, I'm just not sure. I mean, I wouldn't say I'm suspicious. Seems like he got pretty good information from. Who is it that who are you, the two doctors that you're mentioning? One is one a urologist oncologist? I mean, a
Yep.
urinary oncologist?
One is a urologist and the other one is the radiation oncologist.
So that's why I'm thinking about a second opinion. If it's a urologist, but not a oncologist specialist in genitourinary and a radiation oncologist, seems like that you're skipping just the opinion of a real genitourinary expert in the field. And I don't know if your urologist is that kind of a person or not.
No, I don't think he is.
Well, so that's why I was asking about a second opinion.
Okay.
I think, this is a tough one. I mean, because we don't like to send people on a wild goose chase. If we think it's going to change your treatment, then it makes a lot of sense. In your case, if you were wavering between surgery and radiation, then it might make sense to get an opinion from a GU med onc. If you're pretty much decided that you want to go down the radiation route, it's just a question of what type of radiation, then I think that if you're happy with your radiation oncologist and if he's done a lot of prostate cancer work, then it's a good option. I mean, Zalewski, for example, is fantastic. So we all recognize his name, and he's a great doc. I don't know about the people at Northwell. I don't know how much they've done. You've got to be pretty sure that they've done a lot of the work. But by and large, I think you're moving down the right path. Peter, would you add anything into this mix?
Yeah, can you hear me okay?
Yeah.
Just as an aside, Greg, many eons ago, I grew up in Lake Success.
Oh, wow.
Anyway, yeah, the reason I would side with Larry about a genitourinary medical oncologist, they might create a situation, a second-line anti-androgen, like Zytiga or something, rather than just Lupron. I'm just thinking out of the top of my head here. There are medications that weren't around several years ago, quite a bit more effective in combination with Lupron in terms of shrinking tumors and controlling this. If I remember right, you had pretty low PSA. It was only like 4.3 or something, right, Greg?
I'm sorry?
The PSA was relatively low.
Yeah, my PSA was a 4.3.
Yeah, that's pretty low for aggressive cancer. So I don't know how often you tracked it, or whether it's showing indication that it's climbing or whatever, but that's a little bit of an oddball thing for an aggressive cancer, that it would be only a 4+3, unless you're tracking it regularly and seeing that it's climbing. So that's the only reason why I would go with a medical oncologist on your team to kind of track you and keep an eye on this.
You know, I wasn't specifically thinking about in terms of making a radiation decision. I was thinking about establishing a relationship someone gets to know you a little in case this becomes somebody that you need to see over the long term, and you need somebody in 6 months or a year or 2 years in case not everything goes perfectly, or in
Right.
case you don't need to start going to a second person, but I think just to establish a relationship, maybe that's a little overkill, but that's something I like to do when I did.
Anybody else have anything that they'd like to contribute to Greg? So Greg, I think you're moving down the right path. Clearly couldn't hurt to get a consult with a genitourinary medical oncologist to line them up. Maybe somebody, I'm thinking that maybe somebody like Dr. O might be a good option, Len. What do you think?
Of course. He's a GU medical oncologist at Mount Sinai. I don't know how you feel about traveling into New York City. You're not that far away.
No, I'm not.
Yeah.
What is his name again?
William O.H.
Oh, okay.
Dr. O. Yeah, he's very well known. Extremely nice guy. He'll give you all the time you need for consults. Yeah, I love the guy. I go to him. And everybody I know who goes to him has the same opinion of him. I've never heard anybody say that they don't like him.
Okay, I thank you.
Yeah, it's not quite as nice an area of the city as is Sloan Kettering, which is on the Upper East Side. But other than that,
Right.
you can't go wrong if
Yeah.
if you're inclined to get another opinion.
Yeah, the reason I suggest him is because I think he's good at giving a view from above. He's got a real good feel of the sort of the different options and doesn't get too much tied in the weeds, as smart as he is. And he might give you that sort of overview that sort of Larry was talking about a little bit, and you can bounce off your ideas with him. But you're moving down the right path, and just keep checking in with either me or with us or with Peter's group, and we'll help you along. And how long do you think did they tell you you're going to be on the hormone therapy for?
Well, definitely 3 months before the radiation starts, and most likely during, and then they'll make a decision how much is going to be needed after.
Okay. So, don't be surprised. Don't be surprised if they stretch it out to 18 months to 2 years, because you're a 4+4. But again, it depends on how much cancer there was, and some doctors will use less rather than more. What we would say to you is do your reading on the hormone therapy. So there is a very, very good pamphlet. I will put it in the chat window for you that we prepared at UCSF a few years ago, which is a good primer. There's a very good book by one of our advisory board members, Richard Wassersug, and I can also put that in the chat window for you. I think and the reason is because all too often, these docs, when they put you on, they don't tell you anything about hormone therapy. And there are some things you need to know. And probably if you ask these guys in this group, the most important thing they're going to tell you is that you got to exercise.
Yeah.
Because that will minimize a lot of the impact. And you'll come back on here if you're having issues, and we'll give you some ideas and some shortcuts. as to how to deal with the hormone therapy.
Okay.
Okay.
Thank you. All right.
That's a pleasure. So I've just put the UCSF one in, and I'll put the other one in shortly.
How do I find the chat and information that you're putting in?
Oh, that's a very good question. If you go to the top, there's a bubble. You'll see two little like chess pawns and a number. That's how many people are on the call. And next to that, there is a bubble. And if you click on that, it's going to open a window for you. And when you open the window, there's all kinds of links that people have been busy sticking in there. And I am just about to put the link in for the Amazon link for Richard Wassersug's book. And there is he also has a online seminar that you can take. And actually, this is a very good opportunity. Russ, didn't you do the seminar? And how was it?
I'm registered for, I think it's May 12th.
Okay. So you're going to do it. One of our guys just did it. I can't think who it was.
All right.
One of our guys just did it, but anybody remember the name of Richard's website? No. ADT for Life or ABT?
I think it was Life on ADT.
Yeah, Life on ADT. And
that's the name of the book.
Yeah. So now the book's in the window too, and Life on ADT, and you can sign up for these free seminars. And I really think you'll be ahead of the game if you can get your arms around that, Greg.
Now, will this information be here after the talk? I can still go to chat. I don't have to do this right now.
No, you can find this afterwards. The chat window will be downloaded in your computer under Documents, I think. And we also post it when we put the recording up. We post it.
Okay. All right.
Okay. And if you're stuck at all, just ask us and come back to Peter or me, and we'll help you find it.
All right. Thanks a lot.
Okay. So yesterday I spent a couple of hours talking with Scott, who is on our call today. Somewhere. Can't see where he's gone.
I'm right here.
You're right. You're right there. There you are, right in the middle. Okay. And Scott was sent to us by our dear friend, Terry Lakowski. We sort of worked through a lot of Scott's information, and I'm going to just take the use the privilege of summarizing it for you so we have the most amount of time to talk with Scott. And there are a few things that we don't have, and I hope that Scott has been able to lay his hands on them. And also, Scott, you can correct me for any information that I don't get right. So let me just whistle through what I learned yesterday. So Scott, I don't know how. I know you're in your 60s. I don't know how old are you?
71.
71. Excuse me.
I thought, Rick, you wanted me to do the thing, but if you're going to do the intro, that's great.
Yeah, I can. Let me do it because I just want to make sure that we get everything in. And is that okay by you, or would you rather do it?
No, it's just I did get some information that we talked about yesterday.
Okay, so we'll come back and we'll fill in those gaps after I'm done. So Scott is 71, lives in a northwest suburb of Phoenix, and is a teacher. has a couple of sons in their 30s. And in December of 18, he had a rising PSA. He'll tell us what the Gleason is. That's some of the information he was going to give us and what the PSA was. But he had a rising PSA, and they did an MRI. He decided that he wanted to do a radical prostatectomy. And in the MRI right before the prostatectomy, they found a lesion in T8 in the spine. So the local urologist proceeded, he did the surgery, there was extracapular extension, positive margins, maybe a couple of other things that Scott will tell us. And he started Lupron pretty much immediately after the surgery. And then later that year, did adjuvant radiation therapy, but only to the bed. He has some issues with his urologist. The urologist doesn't want to give up the Lupron shots. He had a local general medical oncologist, and the general medical oncologist put him on added Zytiga early this year. I think around February, because the PSA was just continuing to rise. So he'd been on the Lupron, and early this year they added the abiraterone. The PSA still continues to rise. It's gotten up to 0.3 by now. And then an MRI in 2020 showed 3 spots. Scott thought that maybe he should get second opinions, and he started looking at Mayo and MD Anderson, and actually did another MRI at Mayo, and had been considering SBRT, spot radiation, but the report that came back indicated that there were now 5 spots to C1, T1, T8, iliac wing, and scapula. So the doc at the medical oncologist, the general practitioner, general medical oncologist, had not given Scott a very good outlook. He'd basically given him the old 5-year routine, which many of you on this call have heard before. And you know, I told Scott yesterday that's a very average number, and it really depends. He told him he would be on Lupron for the rest of his life, and never mentioned anything about androgen deprivation therapy. Basically told him that chemotherapy was kind of a last gasp treatment. As a result of hearing some of this, Scott has now had a telehealth appointment with Cassandra Moore, who is a GU med onc at Mayo, and he's set up to see another GU med, a radiation oncologist at Mayo. And for me, the big question is, do you do spot radiation at this point in time, or are you beyond the spot radiation, and should you think about other treatments? So that's where we are. And the reason I wanted to give to sort of capsulize it is because there's quite a long conversation in here, and people are going to have different views, and I want to give plenty of time for the conversation. So Scott, can you maybe just tell us a little bit about your PSA history and your Gleason scores, and correct me on anything I got wrong?
Yes, in 2019, I'll go back 2018, then 2019, the beginning. In the biopsy, the PSA was 25 and the Gleason was 9. I think it's 5 + 4. I don't know what that means.
Okay.
And so then I went ahead and had the radical prostatectomy in February of 2019. all you're saying is absolutely true, but here's the clincher. Today I went down to Ironwood and picked up my Zytiga. This is the drug with the $2,100 copay for the first 30 days and then $500, Anyway, I saw the doctor, Dr. Miller, who was the radiation oncologist, and I asked him about what Rick had sent about this SABR radiation. And he looked at me and he said, that is ridiculous. Don't even consider it. I mean, I asked him his opinion. I didn't tell him anything about the Mayo. I wanted his opinion. He said, no, that's absolutely ridiculous. You're trying to, what you're trying to do will just get more money for the docs, won't do any good, and don't even consider it. And I thought, wow. So, but I do have an appointment Friday at the Mayo Clinic with this Dr. Vargas. I'm going to ask, is this a thing? And I did, by the way, Rick found out insurance is okay. And I did send that question to Dr. Moore. Are there too many spots? Should we consider chemo? No answer. But my thing is, my difficulty with the doctors, and Rick's portrayal is pretty accurate, but is simply this, and I'm going to be frank. He came in a room in March of this year, and he said, these spots, cancer's metastasized. I mean, up all the way up until then, it was like, well, we don't know. There's one spot we don't know, and I had 8 weeks of radiation to the prostate bed. And then I had an MRI and another MRI, and he came and he said, well, that's it. You got 3 to 5 years. He had a mask on. He said, I'm not going to repeat that. I was just like, holy crap, And so then I started on the Zytiga, and I had a Zometa injection, but I don't want to say they don't care. It's more like they don't care. It's like, so here you are. Here's the cattle. Let's move to the next one. Here's the next one. It is a godsend to me. Rick volunteered 2 hours to. I did my best, but God bless you for taking the time. I'm going to go see the Mayo guy, but you see, I got this conflict. I got the Miller telling me from Ironwood, that SBR, that's ridiculous. Don't even. And then I've got, so I don't know where I'm at right now. I will say I'm on this drug regimen, but I'm just blown away.
Let me ask you a quick question here. When you saw this fellow Miller, this radiation oncologist today, how much knowledge does he have of the MRI you did last week at Mayo that showed additional spots? Was he aware of that, or did he just think you had the 3 spots from when Ironwood had done it?
He was not aware of that latest PET scan because that information didn't go to Ironwood. No, he was not aware of that.
Okay. So, look, we're not docs, but we can only tell you what we know, and there is clear evidence, and I think I sent it to you yesterday.
I read it.
The SBRT does have value. And you might want to send it to Dr. Miller or whatever his name is, because he's not giving good advice. He may not agree with it, but the fact is it does have value, and it has value in a very interesting way that we're starting to understand, that some of us have known about for years and years, which is that the radiation itself may in some way stimulate the immune system to help it fight the cancer. And I would bet dollars to donuts that this fella Miller has not even heard of the abscopal effect. Now, having said that, is SBRT a good option for you? If you just had the 3 spots, it might have been a good option. It troubles me that they hummed and hawed about you being metastatic when they found a spot on T8 before they even did the surgery. So I just don't get that one at all.
Well, I never got it either.
Yeah. So now, like I said to you yesterday, I don't know that it would have made that big a difference, as the guys will tell you. But I've said enough. Let me throw this out because there's a lot of stuff going on here. It's an interesting case, and I think we can navigate you fairly well. Who would like to kick off with your thoughts on this one?
Have they talked about genetic testing for you at all? Both germline and somatic testing?
I'm sorry, I couldn't hear the.
Has the doctor talked to you at all about getting a genetic test, both a germline test, a mouth swab, and a somatic test of your tumor tissue to
Yes,
see if you've got
the guy at Ironwood mentioned it, but here's the classic. He also said, "Oh, I'm going to give you a referral to MD Anderson and to Mayo." He didn't do anything. I ended up having to do all of that completely on my own. It took me weeks. Plus, all our schools are shut down, so I'm home by myself. But no, he mentioned that. But the thing with him, there's no follow through. You got to go do it yourself.
Okay. Well, you want to follow through. There's a couple of ways to do it, but talk to these oncologists. They can order the test for you very easily. There's one that's a germline test to just take a mouth swab and let you know if you've inherited anything, like a BRCA mutation. And then there's another one that will take your tumor tissue and look for somatic mutations. But it's with such aggressive living cancer, you want to get that checked out because usually doctors think in terms of chemotherapy as a last resort, but it's becoming increasingly smart to do it earlier in the process if it's aggressive cancer, like what you're talking about. I mean, it's a drag. I'm doing it right away, but if you want to know if there are any mutations before you embark on that course.
But the guy at Ironwood, his whole thing, if you don't mind me saying, was you're going to do the Zymeta and the Zytiga and prednisone and Eligard, and that's it for life.
Not necessarily. It could be that there are other options down the road. The way you're describing is you said it was a 5+4 cancer, if I heard right, Gleason 9. I mean, you've got a pretty aggressive thing, and you want to get the best advice you can. I mean, and I know Rick will tell you there's some excellent medical oncologists in the Mayo system there in Phoenix. I think you really want good guidance. So I would bail from this. The other guy and just get the best because you've got a journey there ahead of you.
So let me just say one thing. We did talk about somatic and germline testing last night, Peter. I would go after the germline test. I'm not sure just yet. I would go after the somatic test because you've only got a one-time use of that right now in Medicare. So you have to decide when you're going to do it. Otherwise, you've got to be going back, and it's an expensive test. And I'm not sure this early on that it makes the most amount of sense. I don't think I would do it this early on, but everybody has their own choice. Now, it's possible at Mayo that they can run the test internally, and so it isn't through Medicare. But I definitely think a germline test is appropriate. But rather than, I don't want to confuse Scott too much here. What are other thoughts on this 5-year issue, on the types of treatments that are available, the outlook? Who else has something to say here?
So I certainly had this original oncologist with the 3 to 5 year. Once of my scans came back with a Christmas tree of metastasis, and he said the cat's out of the bag, and we're gonna do chemo and shots, and then I went for other opinions. I did do early chemo at that time 5 years ago, 6 years ago. I've already passed my lifespan, my death date, and I'm feeling okay relatively. Um, I don't know why they didn't discuss, even though going on to Lupron and Zytiga early seems to be as effective as doing early chemo. I don't know why they didn't discuss that with you right off the bat and quickly before the surgery. And the thing I'm thinking about is you've only been on Zytiga or for a month,
Yes.
Scott. So
Yes.
have you had a PSA before and after that yet to see how that's doing?
I had a blood work. The PSA is 0.2.
So went from what to 0.2?
Well, I mean, I don't know historically. You mean like a month ago, 2 months ago?
Yeah, I'm thinking before the Zytiga and after the Zytiga.
It's always been around 0.2, 0.3.
Oh, wow. Really? That's strange. So my thought was that if the Zytiga doesn't show a definite effect over probably 3 month period, then I think that considering going right on to chemo to knock it down to 0.1, 0.2 if possible, is an option to try to get the best result. And there should be a doctor, medical oncologist, to discuss that option with, and definitely not think about that final chemo as the only time to consider chemo. And Zytiga, if you get a great effect from it and it goes down to that 0.23 range, 1.3 range, then you can think about whether you want to wait for the chemo or not, or discuss it or not. But if the Zytiga doesn't seem to be working pretty much after you pass the goal line, I mean the start line, I really think you should discuss doing something that might really knock it down right off the bat if possible. That was really my opinion. Not to rule out thinking about chemo if Zytiga or thinking of darolutamide doesn't have a good immediate effect.
What about the idea of the spot radiation versus being too much for oligometastatic and considering chemo in place of that because there's more high volume mets? Anybody got any thoughts on that? Len, what are your thoughts?
Well, I was just thinking we should hear from Dennis McGuire, since he just recently had SBRT to metastases.
Very good. Yep.
You want to tell Scott your experience, Dennis? We can't hear you.
Yes, can't hear him.
Oh, and your microphone is showing. Dennis, go to the settings cog in the top right and see if your microphone, your computer mic is selected.
In the meantime, guys, we're getting a lot of feedback. If you wouldn't mind, if you're not talking, please mute yourselves. I feel like I'm playing whack-a-mole here.
We got to give you something to do, Jake.
Oh, yeah,
Well,
thanks.
Jake,
Bill.
you know how to do that, so who else would do it?
I mean, I like playing whack-a-mole.
Dennis, we still can't hear you. We see your lips moving, but we don't hear any sound. You don't
No,
have
we
a
can't hear you,
mute
Dennis.
on your headset itself, do you?
Dennis, can you hear us? Nod. Yes. I see you have an earbud. Maybe you should just use your computer.
Could be a volume thing too. Could be the volume off.
Yeah, we've had
Well,
that.
while he's figuring that out, I'll pick up and let him work on it for a little while. Hey, Scott, it's Ken Anderson. I do live here in Phoenix, and I'd be happy to meet with you anytime and chat. Um, your 5-year scenario from your doctor, don't take it to heart for sure. I mean, you're just getting into this thing, and I can guarantee you that, it's something that they all quote. I got it from MD Anderson when I first went there, and I must admit I pressed him on, how much time he thought I might have, and he just kind of threw a number at me. And I wouldn't give it too much thought. I mean, the fact is that there's lots of treatment options. You're just starting. I would definitely say, at least for me, I wouldn't think with multiple Mets that, playing whack-a-mole with prostate cancer is a good idea. I'd probably go for something more systemic, doing SBRT or IMRT or any of the radiation, unless you're getting rid of the gland itself, which it sounds like you already have done. So I'd probably recommend sticking the course with Lupron and abiraterone or Zytiga. But you do need to track your PSA and your labs. You need to keep a close eye on your testosterone level, your PSA, and your alk phosphatates, which measure bone mets within it measures activity within your bones. I don't want to get too much into the deep stuff, but I mean, we can chat about it anytime. I live here in Phoenix. You can call me. Rick can give you my email. I'd be happy to chat with you. I started kind of researching prostate cancer 3 years ago, unfortunately, and I'd be happy to give you some info. That's it for me, baby.
Thank you, Ken. Anyone else? Dennis, Dennis McGuire, do we hear you yet? No. No, you could call in.
Dennis, just reboot your computer. Sometimes that'll do it. Just reboot, sign off, and log back on, and maybe it'll work.
Who else has some?
I wanted to second Peter. I think it was Peter that said, really, if you had a doctor that you thought was unresponsive, or he told you he was going to give you a referral and he didn't, don't hesitate to go to another doc. I mean, I think there's probably people in this call that have switched doctors because they didn't like the service they were getting. I didn't like my first urologist, and I thought I didn't like my second one, but I actually sat him down and said, look, you come highly recommended. I'm told you're like the smartest guy around, but you're just like too hyper. He'd rush into the room, tell you something, and rush out. So I told him if I was going to be his patient, he'd have to sit down and talk to me until I was done talking. And I don't think anybody ever done that to him before, because he then started spending more time with me. So, be honest with him, how you feel, what you think. And if you're really not happy with him, I don't know anything about your health plan or anything, but you can always go get another doc.
Well, that's what we're doing. We're in the process of doing, and I see John Hall is on the call now, and I know you and John spoke earlier on, correct, Scott?
Yes, sir.
Yes, we did.
And was that helpful to you, Scott?
Well, I am sure John is a true gentleman. We got to talk a little bit. He did confirm that Dr. Moore and Dr. Vargas, and John, correct me if I'm wrong, but he was satisfied with them. So I'm going to go ahead with my appointment with Dr. Vargas.
Absolutely. I think they're from what I've heard from several people, they're the top people for Mayo Scottsdale.
Okay. So yeah, I mean, they're definitely, Mayo is good. I think Moore is good. Vargas is good. As we talked yesterday, it's very hard to switch within. And, probably the docs that are a little more senior, we may have sent you there to begin with, but I would stick with them. I mean, my big concern with Vargas, and you've got to be careful that he's not selling you a bill of goods, is that he wants to do this spot radiation when you're not really a good candidate for it. And that's really where Cassandra Moore is worth her weight in gold, because she's the one that should say to you, yes, you're a candidate with 5 metastases, or maybe she sees more than 5, I'm not sure, but you're a candidate for the spot radiation, or she's going to say you're not a candidate, let's leave that and use it just for palliative purposes later on rather than for managing the disease right now.
But the thing is, I left a question on the Mayo website. You know, I sent several questions to her and her nurse. No response. And maybe because my last name's Hogan, you know, it's not like John McCain or something. I'm going to get a response in a week, but I don't know if I'm going to get a response before I see Dr. Vargas.
Okay, well, John Hall, what's your experience been in getting a response out of Cassandra Moore?
I found both Moore and Vargas timely in their responses to me, and very helpful both.
Okay, and when you say timely, like within 24 hours of you sending an email?
No, especially things seems to have slowed down now. It used to be within 48 hours, but I'd say more like 3 or 4 days.
Okay, so I mean, that's where you have to set your expectations, Scott, that it could be 3 or 4 days, and that's timely for some of these docs. And in terms of Vargas, you're not going to do anything, you're not going to make any decisions without talking to Moore anyway, but you now have your antenna up that maybe you're not the best candidate for the SBRT based on the results of this last MRI. I think Dennis McGuire is on the phone now.
Oh, one important point, Scott, I think when you write to them, make it very succinct and very quick, because if they have to read a lot and it gets convoluted, they may not know exactly, you get put off. That's might have been what I understand.
Hey, Rick, Dennis, can you hear me?
We can hear you, yes.
Oh, great. So the good old phone always works. Yeah, so I started my treatment at Sloan Kettering and started with chemotherapy and Lupron, and was able to shrink the tumors. And then I changed doctors about a year ago to the University of Wisconsin, and when they saw me, my presentation at that point, they recommended spot radiation to the prostate gland, which I still have, as well as a few of the tumors in my pelvic area. And Sloan Kettering, throughout the whole process over the last 4 years, did not want to do radiation. But so I just completed the SBRT at Wisconsin. It was 5 treatments, really no side effects, pretty short procedures. So we'll see. I mean, they're waiting for 2 to 3 months before we do any additional follow-up. But I think that's a good indication of how different doctors, different centers of excellence can have different opinions on what to do.
Thank you, Dennis. So we're going to need to move on. Is there anybody else has anything sort of pressing that they'd like to mention to Scott before we tie up the loose ends?
Yeah, Rick, all I would say was, Scott, you can't expect these doctors to be on top of your treatment. I mean, this whole thing about being your self-advocate is absolutely true. You have to push them. And if you don't get a reply in 2 or 3 days and you think you should, send them another email and put it all in capitals. And just say, what the heck's going on? Reply. You know, you do have to be persistent. And I'd say not not even to like 1 to 10, 10 being high. You have to go above 10. You have to be really persistent. And if you want to reply, you have to ask the question and ask it over and over again, and they'll eventually reply. So don't expect them to put you at the top of the list. You have to actually be your own advocate and push. So again, we'll be happy to chat anytime.
John Hall, did you want to say something just before?
In terms of, well, all I'm saying, I'm going in to see Dr. Vargas on Wednesday and start my radiation treatment this Wednesday.
Okay. Okay.
May I ask a question?
Go ahead.
So when I see Dr. Vargas, let's assume I haven't heard from Dr. Moore. What do I tell him? I say, this SBR really, I mean, I don't know what kind of conversation to have with him, because he would obviously be an advocate of doing radiation.
Well, we don't know. Let's not assume. He might be, but he may have looked at your MRI from last Thursday and said, no, you've got too many spots, you've got too many lesions for SBRT. We don't know that. So I think the response to him would be, what do you recommend? And if he recommends treating the lesions, your response is, well, doc, don't you think there's a few too many lesions? I'm not oligometastatic anymore. He's not going to expect to hear that. He's not, I doubt. I mean, I don't know. John Hall will tell us better if that's true or not. I don't know how he is, but, you know, many docs wouldn't expect the patient to say to them, well, to contradict them. The problem is with 5 lesions, you're right on the cusp. You know, some people say 3 is the max. Some people say 5 is the max. It's somewhere between that 3 and 5 number. Also, I haven't seen your last MRI report, and there may be some other questionable spots that might lead them to think that there could be more than 5, in which case you're almost certainly not a candidate. But you have to lead him. You know, you come from the point of being knowledgeable. Take with you that article that I sent you on the value of the SBRT. But you know, that article is clear. It talks about 3 lesions.
Okay, thank you.
Okay. I will put keep an eye on the chat window. I'll put, or Ken, would you send your telephone number to Scott, please? Just
Yep.
person to person.
I'll do it. I'll send my email and telephone number.
Thanks. Okay, so.
By the way, I saw Dr. Vargas first and saw Dr. Moore second. So right. I got my feedback from Dr. Vargas first, and then I saw Dr. Moore second.
Okay, well, you know, I think in this instance, I would want to see Dr. Moore first, because I would really take her guidance on whether she thinks you're a candidate for the SBRT or not. She is your quarterback. I mean, the way that we look at it, and it's different to the way other advocates look at it, we see a good GU med-onc as being your quarterback. And we're not saying that she's going to know the right type of radiation or what have you, but she's going to see the big picture. And she should be the one that calls the shot, whether SBRT is the right treatment or chemo is the right treatment, in our view.
Thank you.
Okay, we got to move on because we've got 45 minutes and we got a lot of guys on the call. And we have one person on the telephone who hasn't identified, I don't think.
He left.
Caller number 2 left?
Yep.
Okay, all right. Okay, so let me go down the list and see who would like some time today. Bill Franklin, anything for you?
No, I'm good, Rick.
Thank you, thank you. Dennis Correa, anything for you?
No, thanks, Rick.
Okay, Joe Blanchette, anything on your mind today?
No, not today. Thank you.
Okay, we're doing good. Larry Fish, how about you, sir?
No, not today, Rick. I have blood work and visit coming up in a week or so, so maybe in a couple weeks.
Okay. Len, anything you'd like to talk about?
I could give a 30-second update on blood work.
Okay. Les, anything you'd like to speak about today?
I've got a question, but it's no big deal. We could wait for a different time.
Okay, we'll see how we do. Nazir, would you like to tell us how you're doing?
Yes, I would like to. I have a few questions to ask.
Okay, you got it.
And Len.
You got it. We'll come to you. Neff Black, anything that's on your mind from down under?
No, all good this end. Thanks, Rick.
Okay, great to hear your voice. Don't be a stranger, Black. Okay.
No worries.
Paul Frieda, anything for you?
Yeah, 30-second blood work update.
Okay. David Maslin, anything that you'd like to talk about today?
I could use about 3 or 4 minutes.
Okay. Jake, anything you'd like to talk to us about?
Not tonight, thank you.
Not tonight, Josephine. Okay. Dennis McGuire, anything more for you?
Nothing new to report. Thanks, Rick.
Okay, I think Alden left. Peter, you want to give us a quick update on your treatment?
I don't know. I think I'll skip it tonight. Just suffer in peace.
Okay. Okay, well, I'll put a question mark. Russ Smith, anything for you?
Yeah, about 3 minutes.
3 minutes, okay. Ken Anderson, anything for you?
No, I'm going to suffer with Peter.
Okay. John Hall, anything you'd like to talk to us about?
No, I'm fine.
Thank you, thank you. Okay, did I miss it? Did I ask everybody? Okay, so why don't let's start with Nazir, because I'm eager also to hear how Nazir is doing. Nazir, the last I recall, the abiraterone wasn't working too well. You were trying to get some testing done in Canada, some foundation medicine testing. Tell us what's going on.
Well, they have sent in a requisition to Foundation One, and they're working on it. They need a justification from the doctor, and the doctor will provide that justification to them. That. Now, the question that I have is that I spoke to Dr. Morgan, and I've spoken to Dr. Levesque, and I've spoken to Dr. Delani, and they all feel that I should be going for that Keytruda and Xtandi instead of the chemotherapy. Now, my question to Len is, the last time I was on this site here, he said there was somebody who had a lot of trouble with Keytruda. How is that gentleman making out now?
Well, it actually wasn't Keytruda. It was a very similar drug called Opdivo, nivolumab. Yes. And he's not doing well, is the answer. And he's decided to stop treatment.
Oh, good. I know. Yes.
To be honest, my big concern with the Keytruda and the enzalutamide is that if it were me, I'd like to see my sequencing done first.
Yes, that's what they are waiting for, the sequencing, and then they will decide.
Right.
Whether I can come in and have all this, go through this. But I just wanted to ask your general opinion of you two gentlemen, Len and yourself. Is it the right thing to do, or go on chemotherapy forget about the other one.
Well,
You try it.
I'll give you my 2 cents, and then Len will tell you, and then anybody else. But the immunotherapy drugs can be really tough on you.
Yes.
Some people weather them really well, and other people have a lot of issues with them.
Mm-hmm.
Now, in your case, once you had issues with the chemotherapy with the docetaxel when you first started it.
Yes.
Then once you settle down, you seem to tolerate it pretty well.
Mm-hmm.
The cabazitaxel is less toxic generally for most men than is the docetaxel. So you could expect to do better. Now, again, you know, even though you fool us and we think you're 65 and you haven't put your camera on so that everybody else can see.
Oh, I don't know how to put the camera on. How do you switch the camera?
there's a switch that says camera on there, or a thing, and if you click it, maybe we'll see that face, that shiny face of yours that's 83 years old, but you could fool us all. There
Okay,
you go. Yes, look at that. Look at that. So, you know, and Nazir, it is, and this is why I really would rely on Alicia Morgans.
Yes.
I just, you know, I have a lot of trust in her. I think she's a terrific doc. Yes. She knows you. You've met her. She's going to have a better feel for which of the 2 medicines you're going to tolerate better.
Mm-hmm.
And it's just really hard to say, and we don't know enough about these damn drugs. There's a similar drug, not quite the same, but a similar drug that just failed, a drug called Tecentriq.
Oh.
I'll let Len pronounce the generic name, but it's a PDL1 instead of a PD1. Yes. And it was trialed with enzalutamide and it did nothing. And, you know, so you've got to say, well, would Keytruda perform better than Tecentriq? I don't know. Len, what have you got to say to Nazir?
Yeah, Rick got a good point there that Tecentriq, which is atezolizumab, an anti-PD-L1 checkpoint inhibitor, did fail in combination with enzalutamide. Now, which one were they recommending for you?
They're saying Keytruda and Xtandi combination.
Keytruda, right.
And pembrolizumab.
Yeah. So I have heard that anti-PD-1 immunotherapy is better than anti-PD-L1.
Yeah.
So I don't know if that will make enough difference in combination with enzalutamide. This is part of a clinical trial?
Yes, it is part of the clinical trial, yes.
Do you know what phase? Is it phase 2 or 3?
Phase 3.
3.
Yes.
Okay, well, that's at least, it got that far, so they must have seen some glimmers of hope in the first 2 phases. But yeah, I agree with everything Rick said. Cabazitaxel can be just as effective as docetaxel, and it's less toxic. They've done patient preferences, patients who've been on both, and by a great majority, something like 2 to 1 or even more, the patients say they prefer cabazitaxel due to its lighter side effect profile.
And the CARD trial just showed it to be more effective than enzalutamide and abiraterone, right? Isn't that right, Len?
What was the
CARD? C-A-R-D.
Oh, CARD trial.
Yeah.
What was in it? I keep forgetting that one.
the CARD trial was the one that looked at the effectiveness of Jeftana, cabazitaxel, and that it was shown to have more legs than the second-line anti-androgens.
Yes, that's true.
But I do think you've got to get onto these docs and get them to sort out this foundation medicine thing.
Yes, they are doing it, and just we're waiting for the doctor to send a justification and as to why it is required.
Okay, because that's really the key, Nazir. That's the big key.
Yes.
What
But I've asked a few doctors around here, and they said that we have patients on Keytruda, and they don't seem to be bothered too much by it. But then there are other people who say it's a deadly combination of Keytruda and Xtandi.
I don't think we know. You know, because it affects everybody differently. That's the reason why. You know, there's no, I mean, when you look at these trials with pembrolizumab and you look at the side effect profiles, you know, there's always a percentage that have serious side effects and a percentage that don't have any side effects. So we don't know where you're going to land.
Yes. And okay, if I do go on this trial and I do encounter side effects and I come off it, which I have this choice to do, will the problems of the thyroid or anything else will come back to its normal position, or it does not?
Again, that's an excellent question. It's one that you have to ask a doctor like Dr. Morgan's. You know, we've seen people recover their thyroid functions. What they did with Richard was they tried to balance him with thyroid meds, but it took him about 3 months to figure out how much medication to give him. And then I've known other men who the thyroid function did not return. But I think there's good reason to think so. But again, that's a medical question that a really good GU med onc like Dr. Morgan's should be able to answer for you. Or the guy at what's the name of the facility? Javinsky?
The center you're speaking of?
Yeah.
Jarovinsky.
The doctor at Jarovinsky who's running the trial, you should be able to get a good answer from him on that too.
Yes, but he was very evasive about giving me a straight answer. He says, well, at one time he admitted that you could lose your life on it. That scared me.
You know, it's so sad that all these doctors are trying to get you on to clinical trials, but they have such a bias that you can't trust them when you ask them a straight question that they should be able to answer, and they can answer because they know, but they don't want to give you the answer because they don't want to lose you as a trialist. And it really bugs me. It's, you know, it's as bad as doctors doing procedures for money. And there's a conflict there's an innate conflict. Anybody else have anything to say about that?
Yep, sadly, it's true.
It is. All right. Well, look, I think you've got two options on the table. What's your PSA, by the way? The last I heard it was at 20. Has it gone up?
Yes, it's 21.5.
Oh, but you know, that is not bad because it was going up and up and up, and yes. So it's really slowed down.
Yes, with the Zytiga, with the Zytiga, yes.
With the Zytiga, yeah. You know, maybe we'll see you turn downwards with the Zytiga. When are you going to get tested again, Nazir?
Oh, but at the end of the month, I can tell you that right now. It will be, yes, at the end of the month.
Okay. And when was the last, what was the date of that 21.5? The end of April?
Yes, this was, I can tell you. Yes, it was on the 23rd of April.
Okay. Well,
every month.
Keep talking to me.
Yeah.
And, you know, hopefully we'll see it. And the most important question, what did your wonderful wife make for dinner tonight?
She made quite a few things. Yes, lots of vegetables and few meat dishes.
Oh my gosh. I just want to tell everybody on this call that I have personal experience of what a great cook Nazir's wife is. So you haven't eaten Indian food until you've gone to Niagara Falls.
Well, you're all invited.
Thank you, thank you. So actually, to be honest, Nazir bought the Indian food from Niagara Falls, Ontario to Buffalo when I was staying with Professor Bill, God rest his soul. So, and it was delicious. All right, we're going to move on. Len, you had a quickie.
I did. Firstly, I'd like to say, Nazir, nice to see you for the first time. Your kind, soft voice seems to match your image. Good to have you with us again.
Thank you.
So I had blood work done on Friday down here in Venice, Florida, and got the results today. An 8 o'clock wake-up call was good news. First time after 6 years having been diagnosed Gleason 9. First time my PSA became undetectable. Their level of, thank you, their level of detection is 0.06. So some might be lower than that, but that's theirs. And it was a surprise because the last two, the PSA was 0.09. So it looked like it was plateauing there, and I wasn't going to get any lower. So this was good news.
Sorry.
Congratulations,
Excellent,
Len.
Len. Congratulations.
Thank you, guys. The only downside, which we all know if we're on hormone therapy, is hemoglobin and hematocrit continue to drop. So they said you're slightly anemic, 12.6 hemoglobin, hematocrit about 38, but that's not bad.
And what medication are you on?
Oh, sorry. I'm taking darolutamide. It's the new one approved in the U.S., but unfortunately not in Canada. The trade name is Nubeqa. And in addition to being effective, it doesn't cross the blood-brain barrier, so you don't get the same. Peter can validate this for me. He's on it also. You don't get the same level of fatigue or mental fog.
Well, I'm suffering from fatigue and mental fog because I've been on this Zytiga for 5 months.
Yeah, it's tough stuff. Jake's been on it. Peter's been on it. I was on Zytiga also. I didn't like it at all.
Yeah.
I felt very tired.
On the blood test numbers.
I'm sorry?
Congratulations on the
thank you.
Numbers, yes.
Thank you.
Anyone else have any other questions for Len or for Peter about darolutamide?
How long have you been on it for, Len?
Since September of 2019, so eight months.
Got it.
Yeah. But what was interesting was that Len did not, when Len went back on the Zytiga, on the abiraterone, he did not do well at all. He felt it right away, and then Dr. O switched him pretty quickly.
Yeah.
So, all right, that's great news. All right, I'm going to keep going down my list here. And Les, you had a quick question. Are you with us, Les? Yes.
No, I am. I missed the button there. I think maybe I should just wait. This is kind of a generic question. If somebody else has got things about their personal stuff, that'd probably be best to cover first.
Go ahead, and I'll worry about that one. That's my problem, not yours.
Okay, I was just going to ask on May 1st, there was an email from us two International with a message from the Doc Mark Mayed from the PCRI fame.
Yep.
Commenting on this HBOT or hyperbaric oxygen therapy. Did you happen to read that?
I did not. It was probably as part of his COVID update, and I've given up reading his COVID updates because they're a little too verbose. But we do know a little bit about hyperbaric treatment in this group from people that have done it. What was your question about it?
Well, I was just wondering on how it works, and I assume that's rather expensive thing. I had a personal experience with both bleeding from the bladder radiation damage and from the rectum. So I did have notable difficulty, not severe, but it's quite consistent. And my doctor, local doctor, put me on Pentoxifylline, which in my opinion does somewhat the same thing at a much more minor impact. But I was just wondering if anyone else had any experience with that drug.
What is the name of the drug that you used, Les?
Pentoxifylline.
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 Okay, well, let's go to Len on this because I know that we've been deferring a conversation that would involve myself and Bill Franklin and Len on radiation proctitis for quite some time. Len, I'm not familiar with that drug. Are you? You're muted, Len.
Sorry about that. I am not at all familiar with this drug. I just did a quick Google, and it says it's used to treat muscle pain in people with peripheral artery disease. So it's an off-label use, I suppose. What is it, a condition you're trying to treat, Les?
Well, they said, in my opinion, it was designed or supposed to do about the same thing as this Hypot or whatever it is. That is supposed to help to oxygenate to speed healing by increasing the oxygen in the blood, and it's supposed to increase the healing.
Is this for radiation proctitis or radiation cystitis? What is the complaint?
Well, yes, for the radiation damage. It's not designed for that, but my local doctor said that he uses it for that purpose, even though it's not designed for that.
Well, we've known people use the hyperbaric. And interestingly enough, on some of the other calls, I think it's the sarcoidosis call, they use hyperbaric treatment to treat the lesions that those folks have. You know, we're aware of some downside from the hyperbaric. Sometimes it works, sometimes it doesn't. You've basically got to go for 40 sessions. There are hyperbaric chambers that you can get for your house. They're, I think, about 20, 25 grand if you want to use them chronically. The side effect that I recall was cataracts, which is a known side effect, but it's one of those they don't tell you about. And we know a guy who finished up with cataracts as a result. Again, we don't have a lot of experience. Let me throw it open. Anybody have anything to say, Bill Franklin or Len or anybody else on treating radiation proctitis?
Well, the research I've done shows that argon plasma gas treatment is the most effective without any serious side effects. And I believe that is the therapy that Bill Franklin had. I don't know if he's still on the call, but he says it helped a lot. It wasn't
I'm still on the call.
Are you still there, Bill? Go ahead.
Yep. Yeah, it helped the first time. I'm looking for something. So yeah, I had basically a colonoscopy to figure out, what all the problems were, and he had said before the treatment that he wanted to be able to do that if he found something, and I gave him the go ahead for that. So, and then after the procedure, he told me he did use the argon laser to a certain extent, but it wasn't like a full blown. That wasn't the purpose of going in, right? But it helped me a lot. It was really very useful. But I did have recurrences after that still, and to this day I still have them. I was supposed to go in for a different exploratory treatment when all of this COVID-19 stuff started, so it never happened. It got put on hold. So
yeah, I was scheduled to have it done today, in fact, up in Manhattan, but I'm still in Florida, and of course because of COVID-19 they postponed it. So I'm scheduled now to June 15. But Bill, I've heard that it's not uncommon to have to do more than just one treatment.
Right, and the other thing he had given me, because I couldn't come in for treatment because I was traveling frequently to Hawaii, was Hydrocortisone Suppositories for when you had a flare up. So just basically at night before you go to bed, and then for like 7 days or so, and that also seemed to help quite a bit.
Yeah.
But if I
that
didn't use
didn't
them,
help me at all.
Yeah, I've been wrestling with this since 2008, and most of the time it's a non-issue. It flares up, and usually it's a minor flare-up. I'm actually going through a major flare-up right now since yesterday, and I'm pretty sure that's what it is. But if it doesn't ease within a couple of days, then I'll have to go in and check out what's going on. But I was offered the argon about 5 or 6 years ago. I think that's where they cauterize a bunch of the veins, and I could see. When I did a colonoscopy, was it, or an endoscopy first of all, a sigmoidoscopy first of all, they actually showed me, and I could see where the inflammation was on the wall. But it is what it is. What did you want to say, Les?
Well, I was just wondering if someone else had tried this drug. The thing is, it's with my insurance anyway. It costs I think $15 for 90 pills, and I had noticed no side effects, and it's not as effective, I'm sure, as some of these fancy stuff, but it was cheap and just pop some pills. And as far as I'm concerned, it did some good.
Okay.
Just wondering if anyone else had any experience with that.
No, but if you've actually taken the pills and then it's a good thing for Len and for Bill to be talking to their doctors about and see what they think.
Yeah, thank you for that, Les. It's interesting. I hadn't heard of it before.
Well, a lot of people haven't. Even the nurse have, when they ask me what pills are you on, and I give them a list, and they say, "Well, how do you pronounce that thing? I've never heard of that."
Yeah, I didn't get the
of
name of the
people aren't.
drug actually.
Len, would you be kind enough to put the name of the drug in the chat window? Pentoxifylline.
Okay.
Thank you very much. We'll put it in the chat window, Bill, for you and anybody else. I'm keeping one eye on the clock here, so that was very worthwhile, Les. I'm glad we took the time to talk about it. Radiation proctitis and radiation cystitis is an unfortunate side effect that a lot of us live with who have had a whole bunch of radiation, and doesn't get spoken about enough. Okay.
I'm sorry. It's not something you want to talk about, right?
Exactly. You don't want to talk about it, but if you don't talk about it, you don't.
Yeah, this company is about the only one. This group is the place we can talk about it. In most other places you can't.
Thank you, Mr. Franklin. That's why we have these conversations.
I just sent Jim Ward a message stating he's missing a good chat.
Okay, tell him. You tell him. All right, let's move on to Paul Frieder, and then David Muslin, and then Ross.
Okay. My recent blood test, normally it takes about 7 or almost 10 days sometimes to get my results. This time I got it back like the next day. So a lot of people, I guess, are not getting blood tests. Anyway, I'm still in remission. The one unusual thing I noticed is that my testosterone went down. Oh, for people who are not familiar with my situation, I'm on the Lupron holiday now for about a year and a half. And my testosterone has been slowly going up. And last time it was like 230, 35 or something like that. But this time it went down to 204. I don't know why it would go down. But anyway, the important thing is the PSA is undetectable. So.
Well, the one thing I will tell you about testosterone measurements are that they are notoriously unreliable. And it all depends what time of day you get them, et cetera, et cetera. So they fluctuate around like crazy.
Oh, so is that right? Okay.
It was 225 last time, and it was 204. I mean, that's pretty much the same measure, Paul.
Okay, I didn't realize that there was that much error.
Okay, and for Scott Hogan, you see, here's a man who's he's on holiday on a Lupron holiday right now, LHRH holiday right now, and these are options that depending on how you respond to the drugs you can do. We've got a bunch of guys on this call who have had significant holidays and all have advanced disease. So, there is hope. There is hope.
Is that the calm before the storm?
Len would not say, you wouldn't agree with that, would you, Len?
What, intermittent therapy, calm before the storm?
Yeah.
Well, you could argue maybe that was my case because I was on drug holiday for 28 months. And then by the time I finally got scanned, as my PSA started rising, I found out I had 3 bone mets, or possibly 5, depending upon whether or not 2 suspicious ones were bone stress fractures or actual lesions. But I enjoyed the 28 months, I'll tell you that. So actually, I forgot, I wanted to mention to Scott, like you, I had 3 to 5 bone lesions, and there was a consideration of getting SBRT or SABR, same thing, treatment. And I spoke to Zalewski, and he said, no, let's wait. Let's wait and see what the darolutamide does. And so turned out to be good advice because without getting any radiation, I'm undetectable now. So it's something for you to consider.
What may I ask? What is darolutamide?
It's a second line anti-androgen like Xtandi or Erlita. The trade name for this one is Nubeqa, Nubeqa. So those are all androgen receptor blockers.
Are they all super expensive?
Yes.
Your insurance hopefully will cover it. It's not expensive for me because it's covered by insurance.
The answer to your question is they are all priced similarly, but hopefully your insurance will cover a good portion of it, if not to begin with, then down the road. We don't have time to talk about the cost of these drugs tonight, but we will definitely, if you're on next Tuesday, we will talk, and some of the men can tell you some of the tricks around getting these getting these drugs paid for. The darolutamide, on the surface, you're not really eligible for it right now, but it is probably the best drug out there. It works a little differently to the abiraterone, but it works very similarly to a couple of the other drugs, and we can educate you about it next time. But I have to keep moving along here because I've still got to get to David Marslin, and I've still got to get to Russ. So, but we can come back to all of those. Make notes of these issues, Scott, so that you can raise them the next time you're on.
Thank you.
And you know, Ken will help you a little bit with some of these issues too. He's very knowledgeable. He doesn't think he is, but I know he is. Okay, David.
Thank you, Rick. Just real quick, I'm just trying to give myself a heads up. I did my second PMSA scan in January, and two metastases on my ribs on number 3 and number 9 came up. It was pretty clear. Hussein put me on the Lupron, and I'm about just finishing my third month and doing great on that. And just when I asked her, what do we do with these two metastases, she said, just don't worry about it. Let's talk about it in 6 months. And we never got into it. The question is, what type of treatments do you think she'll offer? What should I be looking forward to? I've really compartmentalized it and haven't worried about it. And now, just with all this discussion about different types of radiation, I've just thought I'd throw it out there.
So let me just, where are we? Here we are. Okay. So you're on Lupron.
Yep.
So here's and right now we just see a couple of lesions, correct?
Yes.
Okay. The first tricky issue is that these are rib lesions, and one of the other guys may know better, but rib lesions are harder to treat because the rib is so fragile. And I don't know whether you can use SBRT on a rib lesion or not. Do you know that, Len or Peter?
I don't.
You know, if you don't have multiple lesions, and this is the conversation we were having with Scott early on, if you have 3 or less lesions, then there seems to be good reason to possibly to treat them with SBRT. Now, the Lupron could make these lesions smaller and smaller, and we've seen that because they're being starved of testosterone, and you know, probably at the end of after about 6 months, you may get another scan. This is why we scan on a regular basis. If the lesion still showed up, yeah, it's probably worthwhile having a discussion about oligometastatic SBRT, I will send you, David, the same thing I sent to Scott yesterday, because, you know, we think that maybe one of the reasons it works is because it stimulates your immune system. The radiation stimulates your immune system. Len, do you want to just elaborate that theory quickly?
The abscopal effect?
Yeah.
Yeah. Well, again, this is yet another controversial topic in prostate cancer. There are some oncologists who might swear by the abscopal effect, whereby SBRT radiation treatment to a bone lesion can stimulate the immune response throughout the entire body, so that other lesions that were not targeted by the radiation can suddenly disappear along with the lesion that was targeted. Others or other oncologists are somewhat skeptical that it's real. Who knows?
Yeah, it is. I'm going to put the link in the chat window for you right now, David. So you can call it up and save it, and then you can read about it. Okay. Yeah, I think that would be the discussion. I mean, the other discussion would be, do you want to add a second-line anti-androgen that like Peter was talking about earlier on? You want to add enzalutamide or abiraterone? It comes with pluses and minuses. And again, this is something that Dr. Hussain, I mean, yeah, Dr. Hussain is one of the wise old sages. So she's going to have ideas as to when to introduce abiraterone or enzalutamide. I mean, in the old days, namely about 4 or 5 years ago, they never would introduce it early. Now they're talking about introducing it early. Peter, do you want to say something on that?
No, I mean, it was suggested and I do it. I declined. I was nervous about it, but I did go on. I did eventually go on it, but it wasn't right off the bat. The doc wanted me to do it right off the bat, even before I did any kind of primary treatment.
Mm-hmm. So, I mean, I think that these are the issues to be. When are you seeing Dr. Hussain again?
Actually next week.
Next week.
Blood work this week, and I'm going to see her or talk to her on the phone next week.
Okay, well, what we always tell guys to do, and I really believe this is best practice, is make a list of your questions. You don't want more than 5 or 6 questions, max. Mm-hmm. Make a list of your questions, write them out and email them to her, or submit them through your portal, through your Northwestern portal.
Yep.
Because if you do that, she will answer all the questions. She has to, because it goes in your record.
Right.
Okay. This is a really good thing. This is a good tip for you too, Scott Hogan. When you walk into your doctor, have your questions written out, but don't have too many questions. It will scare them away. Have 5 or 6 questions, write them all out and hand it to them in hard copy, if you can do that. If not, email it to them, because that goes in your record and they have to respond to you. And the questions I would be asking her, I think, would be, is there a place for oligometastatic spot radiation for me? What do you think about the idea of going on a second-line anti-androgen? You know, all of them have pros and cons. You know, one of the things we know that is a con against the second line anti-androgens is you can do well on them, be on them for a long time, but it does change the nature of your prostate cancer.
Yep.
And then you finish up with an untreatable type of prostate cancer, which is what's happened to Richard Foodie. And now we're struggling to find a cure, but he got 4.5 years out of enzalutamide. So, you know, there's no, as one of my professors, where's Dennis? Oh, Dennis McGuire. As one of my professors used to say, there's no such thing as a free lunch. Right, Dennis? Milton Friedman, who I was fortunate enough to study with at Chicago. And as he used to say, there's no such thing as a free lunch. So I don't think he ever thought we'd use that in a prostate cancer support group meeting, though. I don't know.
You know, Rick, the way I heard that story told was they asked an immigrant going through Ellis Island who had been in New York for a while, and they say, well, what do you think of America? What have you learned that you didn't know before you came here? And he said, there's no free lunch.
Maybe the immigrant was Milton Friedman's father.
Could be.
I think, yeah. There's a fantastic picture I saw recently. I was listening to somebody from the Stiegler Center, and there was a fantastic picture of Milton Friedman and George Stiegler walking along side by side, both with their backs to the camera. And one of them was really tiny, and the other's this big guy. It was great. Anyway, David, I think that's probably a couple of the questions. And if you've got other things, talk to us and run them by us. Run the questions by us.
Yep, we'll do. I'll get my blood test. I should get my results back this week, so I'll talk about it next week, and we'll put it together before I see you next week. Thank you, Rick. Thank you, guys. I'm good.
So I'm just going to answer Scott here. Scott, you are on the list. You'll get a reminder before every meeting. You should have had a reminder before these meetings. You're on the list, and you'll always get a reminder. Just make sure that info@ancan.org is whitelisted. It comes from info@ancan.org.
Oh.
And make sure that info@ancan.org is whitelisted so it doesn't go in your into your spam folder. And it's always for these are meetings, it's always the same link. The link never changes. Okay. Russ Smith.
Yes, sir. So just a quick update. I had my first radiation treatment today.
Oh.
Yeah, it went well. I'm not sure why I'm so tired, but I've been dead tired, all day. And I don't think it's the radiation. I think it's the stress. But you got one down, 39 to go.
Well, we always said we've told you, get that 15-minute walk in the fresh air after each treatment. It will help you immensely.
We've been doing that.
Okay.
Ron, I had 48 sessions, so maybe that'll make you feel a little better.
I'll get through it. It's just, the anticipation of the first day, the stress, anxiety comes with first day, and it'll become routine in the next couple days. But today was kind of tough.
So did you have to walk in the rain after today, or was it nice?
No, it was actually pretty nice. My wife drove me today, and there was no rain, and it's kind of like personal treatment now at Dana-Farber. You kind of walk in, and you're the one and only, and they all know who you are, and they bring you right back. And I was out in the whole door to door was 45 minutes. So luckily I have Dana-Farber in my neighborhood.
Do take that walk afterwards, so you'll feel much better. I know it'll zap you, like you said. It was probably stress the first day, but
Yep.
You'll get through it.
No, I'll be fine. It's just rough. I'm sure, like everyone, rough first day. Yeah, I'm 15 months off of RP, and just having to go through it again. It's the mental strain, but the upside is my wife and I are building a house, and that keeps me occupied. So,
Okay. So Scott Hogan, do you have any tips for? You've been through this adjuvant salvage radiation. What tips do you have for Russ Smith?
You mean the Lupron or that other one I can't pronounce, the Zytiga?
No, the radiation.
Oh my God, I went through
today.
I went through 39 times of it. And yes, walking. Yes, thank you for asking. Walking was helpful. But I don't eat a lot. That's something I've noticed too. I have to kind of force myself to eat.
yeah, I've lost 10 pounds, which is not normal for ADT. Most people gain weight, but I've lost like 10 pounds because I'm just not hungry.
What is ADT? I'm sorry, I'm learning all this.
ADT is it's hormone therapy.
I see. Thank you.
Androgen deprivation therapy.
Yeah.
Androgen deprivation therapy. I think I sent you the link, Scott, to the hormone therapy booklet. Did I do that?
I don't know. There's so much stuff on here. I'm like, oh my God.
It's a good book. Read it.
Yeah, definitely read it. It's up there. It's up there at 5:34 p.m. Click on it, and then you can save it afterwards.
Okay,
And,
I will. 5:34 p.m.
And the one then, and at 5:35 p.m. is the booklet that you would have to buy, but it's worth it from Richard Wassersug and Co. But that's a very good and worthwhile book to educate yourself. All right, guys.
All right.
Yes.
I'm on Casodex and Lupron.
Right.
Then started the radiation today.
Okay, you demand. You're going to sail through this, Smith. I don't know what we're going to do. You're going to get done with this, and then we won't see you anymore. You'll be gone. That's it.
No.
Okay?
I hope so. I hope I never see you guys again. Because none of you are good looking, so.
Hey, you're going to disappoint Len when you say that.
Well, Lynn is good looking. But...
Okay, and what about Nazir? You should be so good looking at 82 or 83. All right, gents. Did I miss anybody? Is there anything that we need to discuss before we hang up for the night?
Thank you, guys. You're great. Appreciate it.
All right.
So
next meeting.
Right.
The next meeting is next Tuesday, which will be the 12th. Next Tuesday, the 12th at 6 o'clock. At 6 o'clock, not at 8 o'clock. So we'll see you all then, and don't hesitate to be in touch if you need us between now and then. Okay? Good night, everybody.
Have a good night.
Good night.
Feel better, Rick.
Thank you.